So welcome. I'm so delighted to welcome you to our annual NCCNN education event. And it's a virtual event, which actually works really well for this event. It's lovely to meet each other in person, but it means we can get so many more of you attending. So I'm Genevieve Edwards, for those of you that don't know, and I'm Chief Executive of Bowel Cancer UK, which I still get a thrill every time I say that. Luckiest person in the world. And with me is
Claire Coughlin, and I'm Clinical Lead for Bowel Cancer UK, an equally lucky person, I think.
So we've got a packed agenda today. Claire's going to take you through some housekeeping. It's a bit of a gallop because we want to get really stuck into the agenda, which looks fascinating. So Claire, over to you for the housekeeping.
Yeah, lovely. Thanks, Jen. Okay, so firstly, I would just like to thank Amgen Limited, our sponsor for this afternoon. They've provided a restricted donation to support this virtual event, but they didn't have any input into the agenda or the content of this virtual meeting. So thank you.
Thank you, Amgen. We really appreciate it.
Your chat box is the first thing I'd like to mention. So at the bottom of your screen, you can click on your chat box and it will come up in the right-hand side. And if you're in full screen, you can move it about to get it out the way. Please do introduce yourselves to us. Say hello if you can. We'd be delighted to say hello to you and to see you introducing yourselves there. There's also at the bottom of the screen a Q&A box for questions and answers. The window will appear if you click on that. Now, when our speakers are speaking, if you've got any questions, then please do put your questions in there. It's really important you don't put it in the chat, you put it in the Q&A, because the speaker won't be able to see it in the chat, but they can see it in the Q&A. So we'll do as well as we can to cover as many questions as possible. Just to say that today's session will be recorded. We'll be emailing you the link to the recording in the next couple of weeks, so you can revisit all the information at your leisure. And the other thing to say is that we will also be emailing you out a survey just to say how you found today's event, and if there's anything we could have done better. We'd be really grateful if you could complete that for us. We will then send you an attendance certificate, and just to say there's usually a bit of a delay in sending that out because we wait to get everything back first before we do so. So I think that's all the housekeeping for now. Was there something about the chat box being disabled?
I don't think it is, because we've just had a hello from King's Lynn. So
oh, fabulous. Okay, so start chatting now, because I think it was off for a minute.
Hello from King's Lynn. I hope you've got some nice September sunshine. We do here. And hello, Ali, from Lincoln County Hospital. We've got someone from Birmingham, Ipswich. Wow.
We've got Vicky from Lewisham. Hello, Vicky from Lewisham.
And the team in Edinburgh. Hello, Edinburgh. And Watford. Wow, look, this is going to Cheltenham. It's amazing having everybody here. Morecambe Bay, lovely spot.
Oh, that's great. Well, I think we've got a couple of polls.
So. Well, we have absolutely, and I think we're going to move on to the first one. We just thought it'd be lovely to find out who you are and where you're from. So would you mind just popping into that poll? You should be able to see it now. Hi, Anna from St Mark's and Maria from Taunton. Just pop in where you're from. And look at that, that's fantastic.
Oh, fantastic. So we've got lots of people in England, some in Scotland. Oh, we're represented all over the 4 nations. That's brilliant. We've got one, it looks like, from outside of the UK.
Hello. Lovely to see you.
Okay, so just to say that the evidence base and the practice that we're going to talk about today is based on what happens in the UK. Just so you're aware of that, but you're very, very welcome, and we're really pleased that you could join us.
Oh, that's lovely. I think it might be Mary
from Dublin.
Dublin. Oh, lovely to have you, Mary. So should we share the results of that poll so that people can see? That would be nice, wouldn't it?
Yes.
There you go. So that's where people are joining from today. And then our next poll is, who are you watching with? Who are you hanging out with? Is it just you, or have you got other colleagues with you?
How many of you are watching? We love to see that, because then it tells us how many. Oh, that's brilliant. There's loads of you. Me and a colleague, me and 2, me and 4. That's a busy room. Well done.
Yes, that's great. So we just give that a couple of seconds more, and then we can share
the results. Brilliant. We've got loads of participants today.
Yeah.
Lots and lots of, well over 100 people are on this. So there's, looking at that,
Yeah,
many people.
absolutely. Well, we've got what, 250,
265 registered, I think, Jen.
which
that's
is
brilliant.
It's amazing. So so if we share those results and we can just show everybody, so we've got a couple of people with 4 or more colleagues. That's amazing.
That's
and
great.
a lot of you on your own, so that's nice. No distractions, no one else nicking the biscuits, right?
Or the cake.
So that's us by way of introduction. Shall we rattle into the agenda?
I think we should get started.
Yes.
Do you want to go through the full agenda first, or should I just crack on and introduce our first speaker? We've got a really fabulous packed agenda for you this afternoon.
We do. And let's crack on with it, shall we?
Okay, so our first speaker, I'm really delighted to be introducing Professor Katrina Whitaker. She's a professor and lead for cancer care at the University of Surrey. And she's going to talk to us this afternoon about the COVID Coco Study. So she's a chartered psychologist and lead for cancer care in the School of Health Sciences at the University of Surrey. And her programme of research focuses on early diagnosis and cancer, with a particular interest in how people interact with the healthcare system and health inequalities. And Katrina's going to talk to us this afternoon about the Coco Study. And I'm really looking forward to this because I've heard so much about it. So thank you very much.
Welcome, Katrina.
Thank you very much, Jen and Claire. That's a lovely introduction. I'm just waiting for my slides to come up. That's brilliant. Thank you very much. Yeah, it's an absolute pleasure to be here talking about the findings from the Coco study. This is a study that we conducted during the COVID-19 pandemic, and it was funded by the Health Foundation. Why did we focus this study on colorectal cancer? Some of this will not be news to many people in this audience, so I will say this briefly, but the reasons that we chose colorectal cancer as our example here was because we know that stage of diagnosis is key for survival, but we also unfortunately know that there are stark inequalities across the cancer care pathway. So we felt this was a particularly valuable lens for understanding inequalities and how they may arise. And that really dovetailed with the fact that as the COVID-19 pandemic was unraveling, it really provided this opportunity for an insight into inequalities, a very unique opportunity for this. And the reason is that, as you'll all be so well aware, there was rapid change to health service delivery. So that was across, again, the cancer pathway, from how people might have contacted their GPs, how they would have been tested for cancer, and also how teams would have come together to determine a treatment plan. And again, I debated about taking this slide out because the audience here will be very, very familiar with the phases that we went through in the NHS. But equally, I wanted to kind of, I don't know, remind us of how rapidly things were changing. So in March 2020, this real move just to free up inpatient and critical care, it was around, reducing any other routine burdens from care. Phase 2, which was only a month later, was really focused on infection control and expanding the sourcing of PPE. But by July, there was already some signalling about the fact we needed to take action on inequalities. So it was becoming quite apparent that there might be some problems happening, being exacerbated by the pandemic outside of just COVID-19, but back into the cancer care situation. The evidence was, and I'm sure again you're all quite aware that there was just an explosion of research going on at this time. And I was involved, for example, in a UKRI study that was looking at how people were seeking medical help during the pandemic. And what we found was that there was a drop-off, as you might expect. People were less likely to go to their doctor when they were experiencing potential cancer symptoms. But this effect actually was not just about whether people were seeking medical help from their primary care place, but actually how they were referred, diagnosed, or treated for cancer. So there's evidence, again, across the pathway that people were less likely to be referred and so on. As I was doing this piece of work, I came across this typology, which I found quite useful in a way of like conceptualizing why there might have been this exacerbation and challenges in care. So this really categorizes 3 different ways in which there were the problems, unintended often problems with care. And so chronic collateral actually refers to the fact that, you know, some people may just have decided not to attend hospital or attend primary care in the first place. Strain refers to the fact that the system was just completely overwhelmed, and this would have had a knock-on effect for things like patient-clinician interactions. And unintended refers to the idea that there may have been missed or delayed diagnosis because of less direct interaction. So things like over-reliance on telemedicine, and I'll come on to that again in a moment. But also what was kind of heartening to see during this time, that some were also saying, hang on, there might be some lessons here that we want to take forward. Things are happening, you know, innovations are happening in a way they don't normally happen so quickly, and there might actually be some silver linings in cancer care. And one thing, I suppose, for my study and the people that I was working with, we wanted to know whether these effects were socially patterned. So although we knew that there's lots of change, that there might have been huge disruption, we didn't know whether this was affecting some groups more than others. So that's the kind of key to this. So before I go on to describe the Coco study, I just want to acknowledge up front this huge multidisciplinary effort. What I loved about working on this project was that we had a great group of academics, but equally a completely strong and engaged group of clinicians who worked with us from the moment of putting in the grant application all the way through to collecting data and obviously writing up the work. And equally important, we had 2 extremely amazing and engaged patients working with us throughout this piece of work. And this study ran between October 2020 and October 2021. So very brief overview. Essentially, this study had 3 strands to it. Because of the rapid changing nature of what was happening on the ground, we really knew that we had to keep gathering documents and evidence, and the sorts of things that perhaps you as clinicians were receiving in terms of communications about what to do, what to pause, what to how to kind of triage patients and so on. So we wanted to gather and synthesize documents. We wanted to do some in-depth work with people who might be trying to seek help during the pandemic, and also in-depth work with healthcare professionals. So we've completed all of these different components, and I'm going to talk mainly, I'm going to sort of give a snapshot of what we found from both the public perspective, but also the healthcare professional perspective next. So our study with patients was deliberately choosing people who were living or had lower levels of socioeconomic status, so people living in more deprived areas of England, but actually we indexed socioeconomic status by education, and we basically recruited equal numbers of people from lower and higher socioeconomic groups. And we asked them, there were people that had experienced colorectal cancer, potential colorectal cancer symptoms in the last 6 months. They'd visited primary care, and we just really asked them about their experiences. And unsurprisingly, we did find that COVID had changed the way people sought help for their symptoms. So this is at that first point in which people are noticing a change and deciding that they need to seek help from primary care. But unfortunately, we did see this difference between higher and lower SES groups in them describing their experiences. So this was across different things in terms of understanding their symptoms, making the decision to seek help, accessing their GP or primary care, and knowing what to do next. So just to give you some examples, and this is not exhaustive of all the different themes that we found in this piece of research, but I just wanted to highlight a couple, a few. So one of the things that came up for people was around their vigilance to symptoms. And we already know things like awareness of signs and symptoms of cancer is higher in higher educated groups. So that's a problem with cancer awareness. But here it's a step further in that what we found was that people from higher SES groups were talking more about having this increased body vigilance during the pandemic. And part of this was about actually being at home and having more time to pay attention to their bodies. And this is something we didn't see as much in the lower SES group. And we have some potential explanations for that. It might have been about the sort of roles or jobs that people are in the terms that they weren't actually able to stay at home during that time and had, or things like having many more competing commitments that meant that it was more stark in the higher SES group, and they talked about this being a trigger for help seeking. Another key thing was around the expectations of accessing services, and this was really knowing that your primary care point is your first point of contact, knowing what to expect. You know, if the message was to stay at home and you weren't going to be seen in person, what did that look like? What did the triage system look like? And here we did see big differences in how people described accessing that first point of contact. So, you know, being more confident in what those steps might be, and being perhaps more persistent in ensuring that they were seen if they really felt they needed to be. So some misconceptions here about GPs being shut, which absolutely was not the case, and something that I know has been a real challenge for primary care. That, you know, of course they never shut their doors, and they anyway. So that was another angle that was important. And finally, for a patient, the patient example here was about differences in perceptions of safety netting. So really finding that people in the higher SES group felt or perceived that they were more likely to be safety netted. So that means, you know, they had a follow-up plan. So for example, it's not always the case you're going to get referred on at your first visit, but knowing what to do if symptoms didn't resolve. And that was less certain in the lower SES groups. So there I'm hopefully providing some insights into what the members of the public were thinking about when they were trying to seek help for their symptoms, and how that might have differentiated people from higher and lower SES groups and made it more likely to open this existing gap between people's likelihood of seeking help and making that first point of contact. Moving on to the study with healthcare professionals. This we did following the public work, and we interviewed healthcare professionals across the care pathway. So this included those in primary care, specialist screening practitioners, radiologists, gastroenterologists, clinical nurse specialists, surgeons, oncologists, and oncology pharmacists. And we did this as well as triangulating data from policy documents, as I mentioned earlier, and where possible from patients. So of the group of nearly 40 patients that we interviewed, some of those had ongoing interactions, referral, and so on with the healthcare system. And so we kind of triangulated all of that data to try and understand the picture where we might be seeing some gaps emerging. And these were the areas and the main changes that were highlighted to us by healthcare professionals at the time. So that they felt could have an impact on inequalities in care. So that's important because, of course, there's lots of things that were changing at the time, but these were specific things that came out that people felt could be opening up that gap. And this was, unsurprisingly, the use of remote technology, but also the use of FIT to prioritise care in the kind of earlier stages of the pathway, creating COVID-free hospitals, and changes in treatment pathways. For the purpose of this presentation, I'm going to focus on those that actually may well continue or certainly are more likely to have an ongoing impact, because although this work was done during COVID, what we're hoping it will do is help share some learning that is applicable beyond COVID, and why we can shine a light on how inequalities generally might arise. So taking the use of remote technology as an example, and I completely appreciate this is a busy slide, but I just wanted to show you the way that we were approaching this. Essentially, this, and again, this audience don't need to be told about this mandate around moving things where possible to be remote, and, you know, really having to discuss those relative risks, which is, you know, absolutely huge. In March 2020, that signal to move things into virtual remote clinics. And here what I'm going to present is kind of quotes from both healthcare professionals, patients, but also trying to think about what is the silver lining here, because perhaps these are things that we can use to our advantage to help actually address inequalities in care, rather than, you know, talk about how they are always exacerbating inequalities. So for healthcare professionals, there was some reticence about being able to do the same assessments online and whether you get the same quality of information from people, even using video. We were told at the time that although video was recommended, it was hard in practice to get that up and running at times, and so you may have been relying on telephone consultations with patients, and that may have led to challenges in communication, which again will exacerbate issues where people already have more challenges in communicating than perhaps other groups. This would make that gap widen. And from patients' point of view, it was actually quite subtle things about remote technology, not just always the obvious things like there is a digital divide and some people have more access than others, but actually simple things around the understanding how that works. You know, when you're actually at a hospital and, you know, when you're waiting in a waiting room and you've got a booked time for your appointment, there's someone there that if things are running late, you kind of get a sense of how it's working. Whereas if it's a telephone call, how does that work? What does that look like when you're sitting at home waiting by your phone? And what happens if you miss the call? I know that really was quite a stressful thing for people when they were describing their experiences. But as we know, there's a huge silver lining here that is going to, you know, transcend what happened during COVID and was already happening, but has just happened at much more rapid pace. And that's that for many people and for many situations, remote consultations are a fantastic opportunity and one that can help close the gap for people. So, for example, here, we had lots of people describing their experiences of, you know, not therefore having to juggle things like childcare duties, you know, make booking time off work and so on, which again, we know can be more of a problem in groups than others. So that's a potential silver lining there. The second example I just wanted to bring to this group was the introduction of FIT to prioritise care. Again, this was on the horizon, but it then moved very rapidly to become something that was mandated and not everywhere. So this was something that almost opened up some regional differences. We know from our London colleagues that, you know, to access hospitals, some patients had to have had a FIT test in order to be kind of move along that pathway. And what we've heard from GPs particularly was this concern that the FIT test, as we know from the bowel screening programme, directly has this socioeconomic gradient, so that people from more deprived backgrounds are less likely to take part in bowel screening. And would there be similar barriers for completing the FIT test in this new triage pathway? So that's an obvious place where we might see inequalities and that needs really close attention. And from patients, we actually only had a few examples of people who'd completed the FIT, but what we heard in these accounts was this idea really that the onus was on them to follow up on results, and this lack of transparency in what happens next after you complete that test. And you can see here this person having to be quite persistent in having to find out that in fact they didn't have any abnormalities and were not going to need to go on further on the pathway. But again, this has a huge silver lining, potential silver lining, in that we know that the evidence for diagnostic accuracy of FIT is you know, superior to just relying on symptoms alone. So this is something that we can really use for symptomatic presentation of colorectal cancer, but we just need to ensure it's not exacerbating inequalities in care. So those are the examples from the studies. I just wanted, before closing, to really bring your attention to the framework that we've been using to understand what I've described here as the room for manoeuvre, because this is about how at every step of the patient pathway, there are reasons why for some groups of people, and particularly people from deprived areas or people with lower levels of education or other reasons why they are disadvantaged, they are less likely to perhaps seek help in the first place and then continue through the cancer pathway in the same way as people with more resources and more opportunities and so on. And this framework, it's called the Candidacy Framework. It's absolutely, you know, it's been super useful in our research, and it is around how people navigate, how they permeate services, and things like adding in FIT basically add in layers of complexity to a pathway, which we have to acknowledge in order to make sure that they're not exacerbating inequalities for patients. And this goes across to things like appearing at services. So this is the remoteness, making it harder to perhaps convey your symptoms to the clinician, but also how clinicians then adjudicate your care. So again, I didn't describe it in our findings, but in our paper we described the fact that actually there had to be this prioritization of patients, and sometimes that could lack transparency, and sometimes different places were doing this differently, and that adjudication is then actually making decisions about who is getting treatment, who is going to carry on, and so forth. And finally, this autism resistance, we know in our data that patients were quite reluctant to go to hospital, and this also could have an ongoing effect on their care. So this is really my final slide to talk about what can we do to avoid exacerbating inequalities. And this might sometimes seem like quite obvious stuff that we're saying, but I think can really do with you know, being there in the front. So things like signposting to services, and that, for example, in primary care, it was really unclear to people what the flow would have looked like to them. So signposting, this is what's going to happen in this order, is something quite simple that can be done that would help people understand what to expect, when to follow up, and so on. With remote options, of course, we know they're brilliant, but we need to ensure ongoing flexibility where possible. And then this key word really for me is transparency, transparency in how patients are prioritised, and how the uptake of FIT is going to go on this symptomatic pathway, and also in transparency about who holds responsibility, because we know from other research we've done, this is often something that patients struggle with in their cancer care pathway, that they're not sure whose responsibility it is to follow up, or how assertive, or how, you know, on it, or whatever they need to be. And this is something that obviously has implications for inequalities in cancer care. So with that, I will stop, and I'm very happy to take any questions. And once again, thank you for the invitation to this event.
Thank you so much, Katrina. I literally could talk to you all day. I can't tell you how much I enjoyed that. There are so many points I'd like to pick up, but in the interest of time, I've got one question I'd really like to put to you, if I may, just really about inequalities, and any other inequalities that you think are important to consider when providing care to patients. If we could just draw that out.
Yeah, I think that's a great point. So this study was focused very much on socio-economic inequalities, specifically using education as a marker. And what we know is that there are obviously lots of other inequalities we need to keep on our radar. So this might be linked to things like ethnicity, learning disability, you know, transgender, all sorts of things that we have to have on our radar to ensure that we are treating, and not necessarily patients the same, but actually patients who need more help differently, if that makes sense, to ensure equitable care for all. So we are doing work now more on intersectionality, which is trying to look at the interface of these different groups and where people may be particularly disadvantaged. So yeah, we'll keep you updated with our ongoing work. Thank you very much.
Thank you. Thank you. I couldn't agree more about all of that. And yes, please do keep us updated, and I'm sure we'll be in touch. And thank you so much. That was a fantastic presentation.
It really was.
Thank you.
I could speak all day, but I shall hand over to Jen to introduce our next speaker in the interest of time.
Yes, thank you so much for that. That was fascinating. So moving swiftly on, because we've got a lot to get through, and I'm delighted to be about to introduce Dr. Mark Harrison. In fact, I am doing that. Mark's a consultant specialising in bowel cancer for 22 years, and he's a specialist advisor to NICE and has an interest in novel treatments for rectal and anal cancer and new drug integration into management of colorectal cancer. Mark, hello, are you there? Mark is going to talk to us with an update in advanced treatment for colorectal cancer. There he is. Hello, Mark.
Thank you, Mark.
See me. And can you see me?
We can see you and hear you.
Yeah, I'm here.
Lovely. Over to you. Thank you.
So if I press this button, it should all work then, shouldn't it? Fantastic. Yeah. Anyway, I'm Mark Harrison. I'm an oncologist at Mount Vernon. What I'm going to do is I'm going to talk to you about management of colorectal cancer moving forward. So I have to click there, and then hopefully I can move my slides forward. Is that right? And the easiest way to do this is to try and use a real patient as a way forward. And what I'm going to do is I'm going to present one of our patients. He's well known to me and my team because we've been looking after him for years. He's a 52-year-old builder, handyman, and he presented originally several years ago with iron deficiency anemia. investigated appropriately and showed metastatic disease, and at that stage underwent surgery with the possibility of a liver resection, since the tumour was stuck right underneath the liver, and made a good recovery. So pathologically, this was a T4N2 tumour with 10 out of 25 lymph nodes, and showed areas of poorly differentiated carcinoma with mucin, which should be giving you a bit of an idea. So at that stage, we were actively recruiting into the Scot Trial. And I've put this down because I think Scot Trial is quite important for how we're practicing our adjuvant treatment in the UK at the moment. And effectively, Scot asked whether or not we gave too much or too little chemotherapy. And the patient agreed to go into the trial. He was a stage 3 tumour, obviously, since he was node positive. We use Capox because actually it's just more convenient for us here at Mount Vernon. We can treat more patients. And you were randomized to either 3 or 6 months worth of chemotherapy. So that's either 4 or 8 cycles of Capox. And he was randomized to the 8 cycles, which was kind of, at the time, standard of care. So here we are. Scott recruited very well in the UK. It was the largest trial of duration of adjuvant chemotherapy globally. And these are the results. And effectively what they're showing you is, in terms of disease-free survival, 3 months worth of chemotherapy is as good as 6 months. And that's important because by the time you're moving to 6 months worth of adjuvant chemotherapy, you're beginning to run into significant side effects, particularly related to oxaliplatin. And patients who've had 8 cycles of Capox will usually have big problems in terms of finger numbness, increasing problems with diarrhea, and just general overall coping with treatment. So 3 months of chemotherapy is what you need, but he had 6. Anyway, because of the trial, we kept an eye on him. I don't know what other centres do, but we tend to refer back to surgical follow-up following adjuvant treatment. But because he was in the trial, he continued on appropriate trial follow-up. And sadly, in February of 2016, was shown to have extensive metastatic disease. So he had evidence of bilobal liver metastases and intraperitoneal metastases. So at this stage, and again, you may all disagree with me, all options for this man are palliative in nature. There are no curative options available for this guy. I've put down here different if oligometastatic, and though I'm not going to talk about oligometastatic disease today, I think it's worthy of a whole 5-day chat in itself. But certainly if he just had a single liver metastasis or a single lung metastasis, then we might have treated him slightly differently. But in this case, we've got a guy with advanced metastatic disease, no options for anything radical. And as such, the options available to you back in 2016 effectively boiled down to three choices. You could give single agent chemotherapy, 2 agents, or if you really wanted, triplet chemotherapy. And depending on whether or not you can get the funding or the access, you could also consider the addition of a biological agent. And I think in lots of situations, this is perhaps a slightly more difficult consultation or a slightly more difficult decision than perhaps one would initially feel. So what I've done here is my next slide, hopefully, if I can get it to load, sorry, I've gone beyond, is what this consultation really should be about. And we have what I would want, what the patient wants, and of course the third thing is also what the family wants, and invariably they'll have a different opinion once the patient's left the consultation. So what you've got here are the various response rates, the chance of how long you'll live or how long the disease will remain subdued if you have the chemotherapy in those stages. So you can see single agent using either capecitabine or 5-FU. Maybe 1 in 5 patients will actually have some tumor shrinkage with that, and that will probably last for maybe up to 6 months. Standardly, we use doublet chemotherapy, so that's usually with either the addition of oxaliplatin or irinotecan to a 5-FU background. Higher response rates with a slightly longer disease-free survival. And finally, there's the whole idea of a triplet, highly aggressive chemotherapy combination, which again gives you a longer disease-free survival, but comes, as you can see, at the expense of significant toxicity. So it's a debate at this stage, trying to work out what is the best way forward for the patient and trying to take their best interests into account. And also trying to do your best to do something that might be of value. And of course, I've thrown in, you also need to discuss the addition of a biological, if it's available, though I would argue in 2022, they're all pretty much available. So we had this consultation, and the patient was fairly clear that he wanted to have more chemotherapy, mainly because he was a Liverpool supporter. You have to bear that in mind. It was important years for us in that time. So because he was a Liverpool supporter and he thought we might actually do quite well, he wanted more active chemotherapy. So we discussed with him doublet, and given the amount of oxaliplatin he'd had, we gave him some FOLFIRI, planned for 6 to 8 cycles. He had 8 cycles, was re-imaged, and it showed a really good response. And at this stage, certainly I have a dialogue with the patients about continuing chemotherapy or whether or not they want to follow a relatively active watch and wait scenario. More importantly for the patient was he wanted to go skiing. So actually it seemed very, very reasonable for him to go skiing and just to keep a close eye on him. And that went on pretty well until the autumn of that year, when the scan done then showed obvious disease progression, and we discussed restarting chemotherapy, and we restarted FOLFIRI. And what we saw was, over the next year, a continued program of intermittent chemotherapy, whereby he'd have 3 to 4 months of chemotherapy, then 2 to 3 months off, and then we'd just carry on like that. However, by December of 2017, I'd pretty much exhausted all the options available in terms of what chemotherapy you should have. And at that stage, you have a consultation about phase 1 trials, but also at that stage, we were interested in whether or not we could see if his tumor would be DNA mismatch repair deficient. And I had his pathology rechecked, and we saw he was a KRAS wild type, but showed evidence of mismatch repair deficiency. And in view of this, and given some interesting preliminary data that we saw, we were able to access immunotherapy via what was then the Bristol Myers Squibb Expanded Access Scheme. So he was our first patient to be offered immunotherapy via this. And this is some of the data to fit with immunotherapy for our patients. So there are 2 major trials for immunotherapy for patients with colorectal cancer. This is the first one. This is the Keynote 177, which is a phase 3 trial looking at chemotherapy versus immunotherapy in the first line. So these are patients who've been shown to have some form of, in this case, DNA repair deficient tumors, and they've been randomized to receive either chemotherapy or chemotherapy or immunotherapy. And really the take-home message from this is, if you were to look at the slides, there is the top curve in both slides, in both progression-free and overall survival, shows that the immunotherapy is significantly better than standard chemotherapy for patients in this scenario. The response rate is better, it's around 40 to 50%. The progression-free survival is obviously much better. And in fact, the overall survival to date has not yet been reached. So immunotherapy for this group of patients is obviously very, very useful. If you move on, you can see, unsurprisingly, multiple pharmaceutical companies were intrigued by this. This is the Bristol Myers Squibb drug. This is the nivolumab, which is actually the one our patient received, again, versus chemotherapy, but with the addition of another immunotherapy agent, ipilimumab. And again, this shows a very, very good response rate, and certainly a much better progression-free survival and overall survival than we would anticipate for patients who have standard metastatic colorectal cancer. So these 2 trials that really moved into clinical practice very, very quickly, which was that immunotherapy would be an important way forward for our patients. So what I'm going to do now just to really make you have a post-lunch sleep, is explain, if I can, what is DNA mismatch repair. And the picture on the bottom there is a place called Clare Hall. It was part of what was the Imperial Cancer Research Fund. And in Clare Hall, they originally described the biological and the biochemical consequences of what happened if your DNA didn't repair itself properly. So DNA mismatch repair is a type of specific biological set of consequences that makes sure that when your DNA divides, you divide accurately, so you don't make lots of little mistakes in your DNA. It also removes bulky adducts, and by bulky adducts I mean things like the damage caused by cigarette smoking or chemotherapy, and it also prevents your DNA from joining up in the wrong place. So it's got an important role, but it's not a massively important role. And in view of this, it is quite possible for you to be born with a missing enzyme involved in this particular type of biological system. And this is your homework. I expect you all to be able to replace this later on. But what you're seeing here, what you're really seeing here is a bunch of small red and blue and grey dots, all of which represent protein complexes. And what these protein complexes do is travel up and down all our DNA, repairing it when the bases that make up DNA join together in the wrong way. And actually different types of what we call of base misrepresentation are removed by differing complexes of proteins. And it's easy to see that the gene coding for one of these proteins may be abnormal. You don't make the protein, or the protein is slightly abnormal, but there is a lot of backfill. But over time, this will become a problem. And we know this as clinicians because of a condition known as hereditary non-polyposis colon cancer, or Lynch syndrome. And these are people who are born with defects in this particular form of DNA repair. And you can see there are different proteins. This is the MLH1, MSH6. And what we can see in Lynch is the development of early colorectal cancer, usually in your 40s, and it's pathologically characterized by being on the right side of the colon, and often with a large amount of mucin within it. And different proteins can be abnormal. So MLH1, about 60% of Lynch syndromes have that mutation, down to PMS1, which is one patient seen in a cancer-prone family, but they all lead to the same biological consequence, which is an inability to repair the mismatches in your DNA. That's an interesting thing to know. That's a germline mutation. That's also, and that's possibly the one of the more interesting DNA mismatch repair syndromes. There is another way of getting mismatch repair, becoming mismatch repair defective, and that's by something called DNA methylation. All our DNA in all of us as we age gets methylated. And by that I mean you're exposed to the environment, you'll get little bits of damage to your DNA as you go along. And for some poor individuals, that methylation impairs the ability of the MLH1 gene to express the protein. So you acquire a DNA mismatch repair. And that's not particularly common, but it's more common than Lynch, so it's sporadic, and it tends to occur in much more elderly patients. So this is a type of DNA, acquired type of DNA mismatch repair deficiency due in time due to DNA methylation, and one you get as you get older. In time, your mismatch repair is a problem, and you get things called microsatellite instability, which is really just long runs of one or two bases in your DNA, much longer than one would anticipate. But over time, again, you'll start to see mutations or shifts in the various bases, which in turn lead to protein changes, which in time will lead to the development of colorectal cancer. So there are two groups of mismatch repair. Those with Lynch syndrome, which tend to be the younger group of patients, and those with sporadic methylation of MLH1, who tend to be older because they've had longer for their DNA to be exposed to toxicity. And again, I'm not expecting you to be able to repeat this, but effectively, if you follow it around from 9 o'clock, well, actually more like 7 o'clock, what you can see is mismatch repair in turn leads to microsatellite instability, the long runs of bases, which in turn leads to an increased mutational base burden, which in turn leads to development of antigens, in turn leads to development of cancer, but also leads to your immune system becoming very used to the idea of mutated proteins in your system and learning to ignore them. As things go on, you develop a malignancy, you develop a cancer, and what we hope to do with immunotherapy is effectively tell your immune system that you're asleep on the job and re-stimulate it. As such, it recognizes what we call the neoantigens and leads them to die, and you get a response to immunotherapy. So that, in a nutshell, is mismatch repair. I'm not sure I explained it that well, but that's what it is. So let's have a look. The patient, you'll all be pleased to know, has now been on immunotherapy for 4.5 years. His disease has been stable. We've not had any problems. It's certainly not got a complete response, but his disease is stable, and he's had none of the complications of immunotherapy one might expect to see. So we've had no problems in the thyroid, we've had no diarrhea, we've had no adrenal effects. So to date, things have gone very well, and we're obviously very, very pleased with how things are going. Things would be different, however, if he'd presented in February of this year. So if you were to go back and look at him now and say he came to me as a new patient in February this year, well, first of all, I agree, all treatment would still be palliative, but what we would do now, which would be perhaps slightly different to then, is that we would check his pathology for molecular markers to see if there was any other activity we could offer. So we would definitely be looking for Razz-RAF mutations. In fact, we looked for Razz mutations back in 2017. We'd look for DNA mismatch repair, which again I went back and got, but also we'll be looking at things like HER2, because we're also aware that patients with colorectal cancer can express the protein similar to those patients who have breast cancer, for whom a targeted therapy might be possible. It may well be that none of those are particularly useful and you would still offer chemotherapy, but for instance, if he was MMR deficient, at presentation now, I would have gone straight in with immunotherapy rather than gone through chemotherapy before we got to this situation. Otherwise, our chemotherapies remain much the same. We still have access to cetuximab and panitumumab. You can access bevacizumab if you're a real believer. But we also get immunotherapy, and we're slightly moving to a situation where some of the other mutations one can see in DNA, we may be able to action as well. So this is a slightly tricky slide. And what it's trying to tell you, or what it's trying to tell me, because I'm kind of the one who always worries about these things, are there are multiple influences on how we manage our patients with advanced disease. We quite often forget, in our enthusiasm for molecular changes and giving immunotherapy, whatever, that actually we also have to look after the patient, and the patients have lots of other things going on. So comorbidities, we see an increasing number of patients who are on anticoagulants, who've got cardiac problems. Age used to be relatively easy, but we're now being asked to give opinions on relatively aggressive treatment for patients who are in their 80s with, again, comorbidities. Tumor characteristics, that's important. You know, how much tumor do you have? Is it suitable? Could you consider it a liver metastasis, for instance, for surgery? Could you do radiofrequency ablation to a lung metastasis? More recently, we've done a reasonable amount of neurosurgery for patients who have isolated brain metastases. So there are there are lots of influences now on how we treat our patients, both in the first line, the second, the third, and the fourth line. And there's a rather a glib statement at the bottom that therapy should be tailored according to individual patients' needs, but actually it should be. And as we work through how we do things, we have to take equal weighting from the molecular characteristics, patient preferences, as well as the tumor characteristics and site before we move forward to treat our patients. This is a slide just to illustrate something else which is important. So what you can see here, what the circle encompasses is effectively all patients who have colon cancer with metastatic disease. And what it's showing you in the slices of the cheese closest to us as it is, they are the slices of the cheese in which there is an actionable mutation, i.e. there are drugs becoming available which may offer some treatment for these patients. What that also brings to mind, however, is there's quite a lot of that cheese which hasn't got a lot we can do for them, and that also has to be borne in mind. It's all very well getting very excited because our patient has evidence of mismatch repair, but that's 4% of our patients. That still means there are 96% of our patients for whom that treatment would not be appropriate. So it's worth just bearing in mind there are a lot of patients for whom we have no easy actionable DNA mutation. And I hope, as we move forward, we may see more and more, but this is the situation at the moment. So what we have got, however, are a series of newer agents, which are quite interesting, or very interesting. One of the commonest mutated pathways in colorectal cancer is a way whereby signals from the cell surface through to the nucleus are interrupted. And we recognize that when we use the drug cetuximab. What cetuximab does is it blocks signals on the cell surface and stops a drive to divide if you're the cell. And we know that mutations in the Razz protein, seen just underneath the cell surface here, stop cetuximab from working. So we check to make sure if your Razz is what we call wild type, which means it will work, or non-wild type, which means cetuximab won't work. But downstream from cetuximab, from Razz, is another protein, excitingly called RAF, or BRAF. And that triggers in turn another protein called MEK, and then MAP kinase, which do things within the nucleus. Mutations in BRAF are also common, around 5 to 6% of all our patients, maybe slightly higher. And what this means is that patients who have wild type Razz, if you have a mutation in RAF, then cetuximab is not going to work. The mutations in RAF tend to occur particularly within one of the coding signals of the gene, so-called exon 15. It's something called a V600E mutation. We can go into that in detail. And what we find is that if you have BRAF mutations, then what happens is that your tumor behaves very aggressively. It's a very aggressive molecular phenotype. And often patients with metastatic disease are dead within 3 to 4 months. So a way of turning off or correcting that mutation is important. And there have been a number of trials and drugs which do that for us. So here's the different types. Sorry, before I start as well, this is a Razz mutation. So this is above the KRAS, and it shows the difference. The top slide shows the difference between a mutant and a wild type in terms of treatment with what we call an epidermal growth factor receptor. And these have moved into clinical practice, and cetuximab, which is the one we most commonly use, is used relatively frequently. It's not essential, and there are reasons whereby we may not always use these drugs, usually because the side effects can be fairly horrendous, but this is a common problem. We've been able to identify this now for several years. This is the RAF mutation. This is a trial called Beacon. And what Beacon did was look at a way of trying to stop what we call the V600 mutation. You used 2 specific drugs which blocked the mutation and allowed ongoing signaling, and it used a blocker of cetuximab as well. It used cetuximab to block Razz as well. And so this is a Beacon trial. It used 2 tablets, encorafenib and binimetinib, plus cetuximab for BRAF mutated patients. And the patients receive the combination. And what we can see is for those patients who receive the combination, which is the blue line, and then again the yellow line, there was a significant difference in terms of overall survival compared to those who just had standard chemotherapy. What you can also see is that the 3 drugs, the encorafenib, the binimetinib, and the cetuximab on the left, were only minimally better than just 2 drugs, which is encorafenib and cetuximab. And that's, in fact, realistically what we use now for our patients who have BRAF mutations. We offer them encorafenib and cetuximab. It's still not great. You can see them struggling to get to a year, but it's better than the control, where the median survival is somewhere around 7 months. And it's something I think we'll see increasing as we get a better V600E inhibitors. We may see changing over the next few years. The next one is one that we're starting to do trials on. We haven't actually got there yet. And this is the use of targeted antibodies against patients whose tumors overexpress the HER2 protein. So this is trastuzumab deruxtecan, and globally there have been a number of trials in a number of diseases in which HER2 is overexpressed. We're just about to start this trial here, but to give you an idea, there aren't that many patients whose tumor overexpresses HER2, but nevertheless, it's an elegant and clever way of treating those particular patients who do. So what happens is you have 2 drugs. You have an antibody which targets the HER2, so the protein targets the abnormal protein on the cell surface, and that's linked in turn to a normal standard anti-cancer agent, in this case a topoisomerase, the deruxtecan. So you're targeting the tumor by its HER2 expression. Once it's targeted, the drug is released locally and it kills the cancer cells. This is a waterfall plot of patients who have overall have some HER2 expression. The thing to remember about waterfall plots is each of those lines reflects one patient. So you might look at that and think that's amazing, but actually we're talking here about 50 patients. We're not talking about vast numbers of patients. And what the line demonstrates above and below the 0 is whether or not the tumor has progressed. So the ones north or to the top of the line, the 0 line, have got worse on the drug, whereas the ones below the line have responded. And you can see right at the far end on the right, there's a number of patients who've had effectively 100% response, i.e. there is no visible tumor to this particular drug. So this is obviously really, really important and interesting, and we need to move this out to see if we can get further experience in using this drug for the management of patients. I'm going to finish off by another set of trials that we're all running, which are trials designed to try and turn mutated KRAS, so KRAS mutant, into wild type. We're doing that specifically by looking at a particular mutation within the KRAS gene, the so-called G12C, so it's glycine to cysteine. And what we're looking at are very unusual little molecules which target that change, inhibit that change, and so as such prevent the protein, the KRAS protein, from becoming mutated. And there are now 4 molecules being tested globally for this. The problem again is patients who have a KRAS mutated with a G12 mutation are incredibly rare. They're probably around 1 to 2% at most of all patients who have advanced metastatic colorectal cancer. So at that stage, I'm going to say thank you. I've introduced you, I hope, to what's going on, what's just happening, what's happened, what will happen. And I'm sure there'll be lots of other things that are happening. We've not talked about WEE1 inhibitors, we've not talked about CyberKnife, but I think at the moment they're the ones which are the interesting ones. So thank you.
Mark, thank you so much. You illustrated that brilliantly. I loved the case study and I found that really clear. So thank you so much. We've had a comment in the interest of time, I'm just going to share this comment if I may. Just as not a question, but a comment. Excellent talk. I always learn so much from lectures with case studies, and I couldn't agree more. Patience is the cornerstone, and the explanation was fantastic. And I just think the outcome of that was just so heartening that we know we're going uphill, but to see that progress is just fantastic. So thank you so much.
It really is. A couple more comments. Wow, actually explained in English and I understood it. Somebody said, no, it was really, really fascinating. Thank you so much. And it's really heartening to hear about that guy and, you know, his outlook now.
Yeah, no, it's very exciting. He's a really nice guy. He retired and now he's really bored. So he'll come and mow your grass for you if you want. He lives in Hay. It's not far.
That's brilliant. And he got to go skiing, which is excellent.
Yeah, really good. Thank you so much, Mark. And I for one will be watching that back as well to make sure I take all the learning, and I'm sure many other people will. So thank you.
Thank you very much.
So I need to move us on. We could talk to you all day, Mark, but we're going to move on because we've got another fantastic speaker now. So Harriet Watson is going to talk to us now.
Hi, Harriet.
There she is. We can see her. I don't know if you can yet, but she's going to talk to us about diagnostic pathways. And Harriet has looked after, I don't want to say this really because it's the same for me, colorectal cancer patients for over 30 years. She's a clinical lead for the 2-week wait cancer pathway. She's worked with NHS England as a clinical advisor on colorectal cancer diagnostics, leading on telephone assessments, straight to test pathways, decreasing time to diagnosis for colorectal cancer pathways. She's an experienced clinical endoscopist and has co-developed and delivered the first Health Education England clinical endoscopist national training programme, and her area of specialist interest is early age onset colorectal cancer and the use of FIT. So thank you so much, Harriet, and I shall hand over to you.
Thank you, Claire. Thank you, everybody. Good afternoon. Hope you can all see me and see my slides. I was just blown away by the last talk, so just trying to gather my thoughts. It was pretty amazing, right? So I'm going to talk to you about the role of the CNS in diagnostic pathways. And this is going to be some revision for some of you and just a bit of a recap on some areas, but hopefully there'll be some new information in there as well. So some of the slides I'll go over relatively quickly, but of course you'll get copies of the slides and you'll get contact details if you want to pursue any of the matters that I bring up at a later date. So as Claire said, I'm going to cover the use of FIT. We're going to look at early age onset and the role of the CNS in the diagnostic pathway, and look at the different diagnostic tests that we can use for colorectal cancer patients in the 2-week wait pathway, and then look at some opportunities for workforce and endoscopy training. So I don't really need to go over this because you all know this extremely well, but colorectal cancer, as you know, is a pretty common disease. We're seeing over 43,000 new diagnoses a year, and half of those patients may die. It's the 4th most common cancer, and we know that it affects pretty much men and women equally. And we definitely know that the earlier people are diagnosed, the more likely they are to survive the disease. And we've heard lots about that already today. We know that the mortality is very directly linked to the stage of diagnosis. I'll just quickly show this up, but again, this has been spoken about already, and that if we diagnose this condition at stage 1, you've got a 9 out of 10 chance of a better survival. So earlier diagnosis is really key. We hear it all the time, but it's absolutely key to colorectal cancer, and really important that people that present with symptoms are diagnosed as early as possible. We all know the symptoms, hopefully, but they are confusing, as we've heard before. Very definitely the common ones we know, but it is becoming more and more difficult to diagnose people of younger age because the symptoms can differ, and I'll come on to that a little bit in a minute. It's important that you understand the risk, the symptoms of bowel cancer if you're involved in the diagnostic pathway, and particularly around the 2-week wait, a nice guidance, and we will chat through that shortly. But as I alluded to, that undeniably that the symptoms are changing, and there are some non-specific symptoms that are really important for people to be aware of. And when a patient presents to a gatekeeping healthcare professional, and it's not always their GP, there can be multiple differentials. And as we know, rectal bleeding is extremely common, and most people that have rectal bleeding don't have cancer, and it's incredibly difficult for GPs to differentiate between those that might have bowel cancer and those that have a benign pathology or another cause. So really important that a good clinical history is taken, including a family history and a physical examination if possible. And we know with the pandemic, this has altered slightly in terms of patients being seen face to face. We all know how important the blood tests are, particularly around iron deficiency anemia, and really important is the use of FIT. So we'll come on to that shortly. I probably don't need to go over these, but this is a nice guidance, and I'm sure you're fully aware of that. But just as a reminder how important it is if you're involved in any diagnostic pathways. So FIT, which all of you will know about, is probably the greatest challenge for many colorectal services. And we heard Katrina earlier in the Coco Study talking about FIT and how it fits into diagnostic services, and the pandemic certainly played a significant role in changing how we use it. And as you know, it is now a mandatory requirement for all 2-week rate referrals. But it's not available in secondary care. So we're very reliant on primary care in terms of the FIT test being used on patients. And the important thing around FIT is the use of it in symptomatic patients is different to the use of FIT in screening individuals. So as you probably know, FIT, if it's under 10, is considered to be negative in in symptomatic patients. So a patient with a positive FIT is a patient whose FIT's over 10. And in screening, the cutoff is 120. So it's very important that difference is realised, because patients obviously that in theory that are going through screening are asymptomatic. So there's been a lot of debate, and there's still some questions about whether or not patients with rectal bleeding should have a FIT taken. And there's been a huge debate about this at BSG and on Twitter. Some of you may well have been involved in it, but there is lots of evidence coming out that shows that the FIT still has a positive predictive value in patients with rectal bleeding regarding colonic pathology. So IBD, significant adenomas, bowel cancer. And of course, it's important that FIT is taken, if possible, when the patient isn't actively bleeding. It's important that we understand the numerical value, particularly if you're managing stretch services and you're trying to triage and prioritise patients, and when the FIT was taken. Evidence around using FIT in elderly patients may help to avoid unnecessary high-risk procedures. We often get primary care colleagues asking if it's okay to send an elderly patient in without a FIT because they're housebound and they can't easily do it. But in actual fact, we say, well, if it isn't positive, it might be that they don't need to be referred so urgently or at all, and we can manage their symptoms differently. So it is important. It's also important that patients are aware that the FIT test is not a cancer test. Many patients come in on the 2-week rate pathway and have been told their FIT is positive, and because of the implications of a potential bowel cancer, they think it's a cancer test. It's important that they understand it's a test for blood. And some of you may well know this is the algorithm produced by jointly by the BSG and the ACP regarding the use of FIT. And of course, and mostly if we're talking to secondary care nurses and physicians on this talk, we're going to be seeing those patients that come through on the left-hand side of that flowchart. But safety netting is important, and if patients do have a negative FIT, whilst we know it's unlikely, it is pretty unlikely that they're likely to have a bowel cancer, it's still important that there is some safety netting. And if you are referred a patient and you're managing them with a negative FIT, that a good clinical history is still very important. For example, unexplained weight loss, unexplained iron deficiency anemia, because if they've had a negative FIT, it might still be that there is malignancy somewhere, and it might be they need referring on to a rapid access diagnostic service if such a thing exists where you are. but certainly there needs to be some safe netting in place. So I'm just going to go on to talk about early age onset. Probably lots of you know this, but we're seeing a global increase in the amount of people under 50 being diagnosed with bowel cancer. So it's not just in the UK, it is globally. And you may or may not know that Bowel Cancer UK did a fantastic survey a few years ago, looking at the reasons why people under 50 appeared to be being diagnosed very late. We know that this number is increasing, and we've looked at local audit where I work at Guy's and St Thomas's, and we've done some PP work that suggests that lots of these patients are experiencing a delay to their diagnosis, and are being managed for what may be perceived to be a benign cause of their symptoms, and not being necessarily referred for a diagnostic test. And this correlates with lots of national and international data. We know from evidence that particularly 1 in 4 patients are being diagnosed as an emergency, compared to 1 in 7 of older patients, and that they are diagnosed at a later stage. I'll just come and show you some data in a moment. And obviously we know that means that their chance of survival can be worse. We all can relate to younger patients, particularly in the media. There's been some very high profile people talking about their experience of bowel cancer, and most importantly, Bowel Babe most recently has really raised awareness of bowel cancer in younger people, and how important it is to talk about your symptoms, talk about your poo, talk about how you're feeling to people, and to try and encourage people to understand that bowel cancer can affect younger people. It's not necessarily a disease of old age, and that trend is definitely changing. This is the Never Too Young campaign that I alluded to earlier, and I would urge all of you to go onto the Bowel Cancer UK website and have a good read of that. We kind of talked about this a little bit earlier on, but the symptoms can be very difficult for gatekeeping healthcare professionals to differentiate, as I said, and that's why the use of FIT is so important, particularly in younger patients. You get these kind of vague symptoms of abdominal discomfort, abdominal pain, not necessarily the typical symptoms of bleeding, together with a change in bowel habit. Obviously, in a younger patient, the first differential might be irritable bowel or IBD, but the use of FIT takes some of that challenge away. Just a quick look at some of the evidence that came through from the Bowel Cancer UK survey, and again, you'll get these slides in time, so I won't go through all of these, but there's very definitely a sort of three-pronged reasoning for why these younger patients appear to be a delayed diagnosis, and some of it focuses around the patient's perception of their symptoms, and that appraisal of their own symptoms not being serious. I can't have bowel cancer, or not even being aware of bowel cancer. Healthcare professionals, again, not necessarily thinking of bowel cancer as the first thing in a younger patient. And then there's the symptom-related factors, particularly with the pandemic, around getting appointments and taking time off work when you've got a young family, a busy job, etc., etc. So there are a different set of issues for younger patients being diagnosed earlier than potentially older people, and it's important, I think, when we're in these positions within the diagnostic service for bowel cancer, that we're very aware of the difference younger patients face, problems they face. And you'll have seen that the sort of tide of information are going through the evidence with regard to young people, and this came out in March, quite a key paper in trying to implement some change, as I mentioned, globally regarding early age onset bowel cancer, and trying to raise awareness. I was going to, I think there might be a slide missing, but that's fine. Some of the evidence that I've looked at personally is that we know younger patients take longer to get diagnosed, so 250 days compared to 150. Typically, they seem to present with left-sided cancers more than right-sided cancers. Whilst there is a genetic element, and we've heard a bit about Lynch syndrome, there is also a high percentage of patients that under 50 that are coming through that have no family history at all of polyps or cancer. The disease is often more aggressive at diagnosis and at a later stage. I've been doing some work with a systematic review, looking at some of the facilitators and barriers to young patients. Some of this I've kind of gone through, but the knowledge and awareness of colorectal cancer that affects younger people is one of the big issues. The use of FIT we've talked about. The barriers is, again, younger people and healthcare professionals are minimising the symptoms, thinking they're not likely to be due to bowel cancer. There's obviously a huge element of anxiety and fear still around going for invasive procedures. That may be more prevalent in younger patients, some of it related to the fact that they need to take time out of a busy life, job, work, family, etc., to attend. We know that young adults and gatekeeping healthcare professionals are more likely to dismiss their symptoms if they're under 50 than older patients. There is a high rate of non-attenders. We know that young adults are more likely to not attend for an appointment if they haven't been referred urgently, so they don't necessarily regard the appointment as important if the healthcare professional that they're dealing with has referred them routinely, because they think their symptoms probably are nothing to worry about, therefore, and it sort of drops down their priority. We also know that young adults are more likely to rely on digital technology, and we heard a little bit from Katrina as well about that, and that was one of the things that certainly became apparent from the systematic review. This is some data from Guy's and St Thomas's, where I am, and just shows over the last 10 years or so the increase in that age group, which the red circle is covering up. It says 33 to 39, and how many more patients we've seen with regard to bowel cancer over those last few years, and not necessarily, as I mentioned earlier, all of them have a family history. We know that the histopathology is often quite adverse in that younger age group also. And we've kind of probably talked a little bit about most of this, but the important thing is to focus on the prompt recognition of symptoms, avoid dismissing them, trying to put bias aside and not thinking because they're young it won't be bowel cancer, carrying out a FIT, carrying out a family history, making sure the patients have really good patient information once they've been referred so that they can choose the diagnostic test that suits them best. It might be that a capsule is better for them than a colonoscopy, for example, and I will come on to that in a moment. Really good communication between GPs and your own teams about the services that are available, the different diagnostic tests that are available, and perhaps working with some of the transformation teams in setting up systems where digital access can help the access from primary care to secondary care. And this is the study, the dysuser study, the FIT study that Katrina also alluded to earlier, but in particular this one relates to younger patients and how important the use of FIT is in diagnostic accuracy for large bowel pathology, not necessarily cancer, but certainly pathology, serious bowel disease in the younger patients. So I'm just now going to talk a little bit about the role of a CNS, and my role is very much focuses around the referral and diagnostic pathway of bowel cancer. So I'm going to talk a little bit about the telephone assessment pathway and the clinical endoscopist training route. There's obviously lots more that the CNS is involved in different parts of colorectal cancer care, and I'm sure there's lots of sort of oncology nurses here and colorectal cancer CNSs. And some of you may have a role that sort of tips into the diagnostic pathway, but not necessarily heavily involved in it. But there are other arms of your role, including education, training, research, and of course leadership. So I'll quickly whiz through the straight to test pathway that we have here, but you will get a set of these slides, but some of them are a bit data heavy, and so not necessarily time to go through it in detail. But you'll know, most of you, the traditional 2-week wait model where a patient is seen in clinic, they have a 20-minute appointment. Not many people do rigid sigmoidoscopies these days, but initially what would happen is a rigid siggy wasn't very effective. They'd not usually had any prep, and you're kind of just telling the patients that they're going to have a diagnostic test, and they come in just to be told that, really. And that has the capacity to carve out, and you've got routine patients waiting a long time, to have appointments when in actual fact there might be patients with cancer sat in that routine group. So what we've set up is a straight to test pathway where we aim to diagnose all patients with bowel cancer in a more timely fashion. We found it reduces our wait times on our pathway, increases the capacity because you're avoiding unnecessary outpatient appointments to just tell patients they need a diagnostic test. It helps you to manage your endoscopy services, definitely streamline the patient's journey if it's a true straight to test pathway. And it provides continuity because you've got the same nurses running the service and the same nurses providing the clinics. It really helps in managing a surge in referrals. So after Bowel Babe, we had a surge of 2-week wait referrals, and we're able to lay on a few extra clinics to cope with that surge. And it provides a flexible service. You don't need an outpatient clinic nurse. You don't need a room. You know, you're sat there with your computer, your phone, and your patient on the other end of it. So you'll probably all realise that the traditional 2-week wait pathway looks a bit like this. And what we aim to do with the straight to test pathways is shorten that time considerably. I'll just go through some of the steps. Some of this we've already talked about. So how it works for us is we have a nurse-led service. So I'm as the consultant nurse in charge of the service, and we have a team of CNSs that are both colorectal cancer CNSs, nurse practitioners from the colorectal ward and nurse endoscopists, and we all do telephone assessment clinics. The patients are booked in via the 2-week wait office for the appointment, and then we assess them and we triage them for the most appropriate investigation for that patient, whether it be colonoscopy, CT colonography, capsule, CT cap. Might be that we actually think they need an outpatient appointment, but that assessment is made at that appointment. And it's a protocol driven pathway. So the consultants in the team have agreed the pathway. It's all been agreed at consultant level, and we're able to speak to the patient on a booked time appointment. So it's like any other appointment, and then we book them for their procedure there, and then referring them through to the hotline for radiology or endoscopy. Bowel prep then gets sent out in the post, and we might have some second stage telephone assessment for the higher risk patients. Some of these benefits I've kind of talked about already, but it's certainly the biggest advantage is that we're speeding up the time to diagnosis for patients. It's pretty flexible and easy to set up. It provides a high quality and appropriate triage because you've got the same team of trained nurses doing it. You get you get a good quality of counselling for the patient in terms of consent for the procedure, understanding what might happen next. Surgeons love it because it frees up them to see more complex cases and to operate, which is what they love doing most. And we've had really good positive feedback from our GPs and our patients. Sorry, it jumped ahead. So this is the algorithm that we work by, and it's not complicated. The patient comes to see the GP refers them to the 2-week straight to test pathway. Our 2-week wait office manage the bookings. The patient has a telephone assessment. We try to see them within 3 days of their referral so that we can get their diagnostic done within 14 days, and then we refer them on for one of those tests. After the tests, all the results are reviewed by a consultant, and that may be myself or one of the colorectal surgeons in a virtual clinic. Some of you may have done this, but there's a telephone assessment training package which we've set up with eLearning for Health. And if you go to this website, you can work through the programme. It's all online, and it's for any colorectal service that wants to set up straight to test with their nurses doing some of the telephone assessment. And it goes through several modules. So first of all, getting started, how to set up your service, then looking through some of the colorectal pathologies, the role of telephone assessment in the straight to test pathway, what type of test you would offer and for what patients. Then it looks around self-assessing your, going back and assessing what you've learned, and then doing some summarising and some learning key points for going forward. So by all means, check out the eLearning for Health website where you can participate in that training. You just have to register on their system. So the downfalls of straight to test, and there are some. When you're setting it up, it definitely needs a bit of micromanaging in order to avoid breaches. You're kind of making sure patients are sticking within the 14 days. You do need a lot of groundwork initially, so you need lots of cooperation and compliance from some of the GPs and patients. And it's now become our usual practice, and we've been doing it for many years here. You do need high quality referral information from the GP, so you do rely on the 2-week wait pro forma being well completed with the right information and the right quality information. And we've done lots of groundwork with GPs in making sure that is the case, including the FIT results and the EGFR, etc. And we still get a bit of skepticism from some medical traditionalists that think having a nurse-led approach can sometimes mean that they're not getting that specialist opinion when they're referred to the colorectal services by GPs. We certainly don't have that here, but I know that has happened in some units, and I've experienced it in other places. You do need to definitely engage with your GPs and your commissioners before you get set up. It's really important that they're on board because they're paying for that service. You need to establish what you're going to be getting within that tariff. Lots of GPs do want to know they're still getting a specialist opinion, and that might be that reassurance that the protocol is consultant approved and led, and that it's not that they're just being referred for an admin checklist, which is what some GPs express concern about. So that's really key. I'm not going to go through these in the interest of time, but you will get copies of these slides if you'd like to. But just to say that most patients that come through because of bowel symptoms being extremely common in the population are found to have no pathology or non-significant findings such as hemorrhoids or diverticular disease and are referred back to their GP. Patients and GPs have been extremely happy with the service, and we've done several Survey Monkeys. Patient satisfaction has been very high. And there is a paper that we wrote quite a long time ago now, but have a look at that. And it's important that you go out there and disseminate your practice once you've got something set up so that others can learn from it. There's more than one way to skin a cat, so the way we do it here might not work for everybody, but modifying that pathway and working through what works for you locally is important. So as I alluded to right at the beginning, there are lots of other roles and responsibilities for CNSs within the diagnostic pathway for colorectal cancer, health promotion and raising awareness. We know that lots of bowel cancer is avoidable with an increase in fibre. Again, on the Bowel Cancer UK website, you'll be able to find that information. But health promotion, raising awareness of bowel cancer is really important. It's important in early diagnosis. It's important in avoiding, minimising the risks and avoiding patients being diagnosed too late. Most of our nurses that do our straight to test are non-medical prescribers with advanced clinical assessment. So if you're interested in these types of roles, then those are the sort of routes that you perhaps want to be looking in. Clinical endoscopist is my other hat, and we'll go on to talk about briefly about that in a moment. Genomics and family history, obviously not covering in this talk, but that's another big area in terms of diagnostic pathway and knowing the risks. We have some capsule endoscopy readers and practitioners here that have been very heavily involved in the diagnostic and pathway for colorectal cancer, and CT colonography liaison, and we've just appointed a CT colonography liaison nurse, which has been a really important role. I won't go into that, but CT colonography. So we've developed a service here. We know that we're lucky and not everybody has a really strong CT colonography service necessarily, but it's particularly good for the elderly patients that, or patients that just for whatever reason are not keen on having an invasive procedure or can't have the bowel prep for colonoscopy. There are advantages in that you find extra colonic pathology. So if you've got those patients with the vague symptoms of weight loss, iron deficiency, anemia, CT colonography can sometimes be a really useful tool, a diagnostic tool. We, like our endoscopy patients, we send the preparation out in the post, which is for us fecal tagging, or we have a version where they also have bowel prep if they're fitter. And as I mentioned, then we've got a CT enema pre-assessment nurse that we've just appointed, who's helping to avoid our loss of capacity for people, patients that are referred on this pathway that perhaps are finding the instructions difficult, haven't received the bowel prep because they tend to be the older patients. There can be some issues with just getting that information to them accurately and succinctly that they understand. So that CT enema nurse has been invaluable, and we're just setting up a service now to try and improve our attendance for CT enema. Many of you will use colon capsule, and this is a really great test for the younger patients. It's, as you know, probably it involves quite significant large amounts of bowel prep, so it's not right for everybody, but it is great for young patients that don't necessarily want to have an invasive procedure. And we just do some of our colon capsule from home, so we send it to them in the with a courier. They get sent all the equipment, so you might have seen some of this, but they carry this pack around with them whilst they take the pill. And we have our practitioner who manages it all remotely. So it's a really good test, and it's important to just know that that's available. You probably have heard of some of the studies that are taking place nationally with regard to colon capsule, particularly post-pandemic, in order to assist with the recovery work from endoscopy. So if you are interested in a capsule role, or practitioner role from an endoscopy, then it's definitely an area to consider. Most of our telephone assessment nurses are prescribers because many of them are endoscopists as well. So that's another area of advanced practice that we would definitely ask you to consider if you'd like to go down that route. Most of it is centrally funded, so you can find, if you contact your practice development teams, you will find probably that there's a course set up near your trust that you can attend. Advanced practice, is kind of part of what we're doing with some of these roles, and it's important you understand the framework and the advanced practice clinical guidance from HEE. If you're interested in taking up these roles, there's lots of there on the HEE website for you to explore if you're interested. And this is the Clinical Endoscopist Training Programme. So if you're interested in becoming an endoscopist, again, go to the HEE website. We've been running this programme now for several years, and it's proven to be a huge success, and really, we probably had over 500 endoscopists through the training program now, and we now can train in flexible sigmoidoscopy, gastroscopy, and we've now extended it to colonoscopy. So if you are interested and you'd like to learn more, you can either go to the health education website, or if you'd like to contact me directly, I can give you some more information. It's a 30-week program if you're doing flexible sigmoidoscopy or OGD, and a 40-week training program if you go to colonoscopy, and you train in-house. So this is for the theoretical and supportive learning, and it's a modular program where you undertake some study days with a university, and you do some e-learning, so there's some lesion recognition training, etc. You have a portfolio to complete. It's quite a comprehensive and quite full-on training program, but it's extremely the format and the schedule is, most people really enjoy it because it's very structured, and it enables you to advance your learning in a very systematic way. And we've seen lots of success, and lots of people come through, and I'm sure there's people on this call that may have been through it. So by all means, take a look, and if you're interested, let me know. Definitely have a go if you're thinking about it and you're sat there thinking, I'd like to get involved, but I'm not really sure what avenue I'd like to go down. Then have a think about the challenges you need to overcome. Have a chat with your line managers, have a chat with your colleagues, and if you'd like to have a chat with me, also Claire at Bowel Cancer UK will be able to give you lots of resources and help. So not do it just because you think it's taking you out of your comfort zone. It's really important that you consider these things if you want to develop yourself. Thanks very much.
Thank you so much, Harriet. People were obviously really engaged in that talk, and we got loads of questions. I answered lots of them as we went along.
That's great.
Just in the interest of time. So I've just got one really quick one, if I could. So with regards to 2-week wait referrals, and in particular straight to test, how do you manage referrals which are incomplete, i.e. no blood tests, no Rockford or frailty scores? I know that's a common problem. So if you could just do a really quick answer, I'd be grateful.
Yeah. So we don't delay the referral. We still assess them, triage them, and hopefully book them for a test, but we will do some of the chasing in the background. And we have a really fantastic straight to test coordinator who is a Rottweiler at chasing GPs for bloods, etc. And that is really key to the straight to test service, having that support and structure and backup in place. But we don't delay the assessment. We still continue with it, but we just do the work in the background whilst we're doing.
Yeah, that's the important thing, isn't it? Not delaying it. Thank you so much, Harriet. That was a fantastic and really interesting talk.
So much.
My pleasure. My pleasure. Sorry, it's a bit crammed in, but by all means, please do contact me if there's any information that people want afterwards.
Thank you.
Thank you. We'll take up on that offer. Yes, so much to think about there.
Yes.
Really, really important. So I'm going to move us straight on now because we're running a little bit late. But I'm delighted to be able to introduce to us Dr. Ellie Mostiopolu, and I hope I pronounced that right, Ellie. Please forgive me if I didn't. Ellie's mixed methods researcher at Queen Mary University of London, and Louise Goodwin, who's a research nurse fellow at Sheffield Teaching Hospital and Sheffield Hallam University, and they're going to be talking about the Shuriken Study, which looks at psychological intervention to improve the quality of life for people living with and beyond cancer. So welcome, Ellie and Louise.
Hello. Excellent pronunciation there.
Thank you.
Great. Okay, so I will be starting this talk today. Hello, I hope you can all hear me well, and thank you for this opportunity to talk to you today about some of the work that we do in the Shuriken Study, which is a study that is looking to develop and test a new psychological intervention to improve the quality of life of patients living with and beyond cancer. So to start with the background to Shuriken, let me just try this one more time. Great. There are currently more than 2.5 million people living with and beyond cancer in the UK, and we know that this number is set to increase. We also know from the literature that about 1/3 of those patients report a very poor quality of life, and that is mainly due to the physical and psychological consequences of their diagnosis and their treatment. And if we take a closer look at some of the common issues that patients face after treatment, we know that high rates of distress, such as symptoms of depression and anxiety, as well as fatigue and fear of cancer recurrence, are very commonly observed across different types of cancers, both during and after the treatment. So these are some of the issues that are likely to affect patient quality of life. And we also know that poor quality of life is associated with unemployment. And in fact, 1 in 3 people diagnosed with and treated for cancer are of working age. And although patients themselves suggest that going back to work and being employed is beneficial to them in terms of their well-being after the diagnosis, evidence again shows that cancer survivors are more likely to be unemployed compared to their healthy counterparts. So that's another aspect we need to take into account when we're thinking about how to improve patient quality of life. And in terms of the interventions, so the tools that we've got available at the moment to improve quality of life, our group did a large systematic review of reviews a few years ago, and we found that talking therapies such as CBT and mindfulness-based stress reduction, as well as exercise interventions, were moderately effective. So talking therapies were moderately effective, particularly so in the short term, whereas exercise interventions were effective both in the short term and in the long term. So since current best approaches are only moderately effective, we decided to trial a new type of psychological therapy, which is called acceptance and commitment therapy, because we thought it is particularly suitable for this population, and we may ultimately succeed in providing better aftercare for our patients. So why ACT? So ACT focuses on acceptance of the things that we cannot change. For example, the fact that we may receive a cancer diagnosis, or the fact that the cancer may come back after treatment. And ACT encourages individuals to commit to a values-based living. So we all have a set of values, but we're often growing distant from our values. So ACT helps people to reconnect with their values, become again aware of what matters to them, and to commit to goals that are in line with those values. And unlike other therapies, ACT does not try to reduce symptoms. So it's not concerned with any maladaptive thoughts that we have, any negative thoughts that we may have, and it's not concerned with symptom reduction. So ACT focuses on the relationship that we have with our unwanted thoughts and symptoms, and it promotes meaningful activity in the presence of adversity, therefore promotes, as they call it, psychological flexibility. So because of its focus on values, we think that ACT is particularly patient-focused and a flexible enough therapy to be helpful for patients from different cultural backgrounds and for patients who face different difficulties and have different sets of abilities. So in that way, we think ACT is very transcultural and transdiagnostic, if you like. So the Shuriken study aims to develop, pilot, and evaluate a novel person-centered psychological intervention, which is based on acceptance and commitment therapy. And it is designed for people who have completed their hospital-based treatment for cancer with curative intent, but they experience poor quality of life. And in Shuriken, we're working with 5 different groups of cancer patients: head and neck, breast, urological, lower GI, and hematological cancer patients. And this is an overview of the Shuriken program of research. So as you can see, it's a very large project, and it consists of 6 interlinked work streams. So the work streams on the left-hand side, work streams 1, 2, and 3, they focus primarily on the refinement and the optimization of the proposed intervention, whereas work streams 4, 5, and 6 focus on delivering a large randomized control trial and then evaluating the intervention and understanding a little bit more about how it works and for whom. And at the moment, we're in the middle of our large RCT comparing ACT Plus to treatment as usual. So what does the ACT Plus intervention look like? And I'm sure you've noticed the little plus symbol next to ACT there. Because we know that exercise is beneficial and work or meaningful occupation can be very important for patients, we decided to integrate ACT with options to support exercise and work if, however, these are deemed important by the patient, so if they are in line with individual values. We call our intervention ACT Plus. It consists of 8 sessions delivered weekly or fortnightly and delivered by a trained therapist. Therapists also receive monthly group supervision, and they're further supported by a written manual. Participants also receive the ACT Plus Participant Handbook, which includes resources and exercises to promote engagement in the therapy. And I also wanted to tell you a little bit more about our approach to intervention development and how we went about creating the ACT Plus intervention. So we have adopted a theory and evidence-based approach whereby we're collecting insights from different sources of evidence at different time points in order to inform and optimize the design of the intervention. So we started with a meta-synthesis in our workstream 1, so the very beginning of the Shuriken project. And essentially what we did was to go back to the literature and identify qualitative studies that would highlight any cultural influences that we needed to take into account when designing the intervention, because we did not want to design an intervention that would be applicable only to some in the diverse UK society that we live in. And moving on in workstream 2, we did a lot of qualitative work. So we had interviews and focus groups with patients, healthcare professionals, and therapists in order to gather their views on the proposed intervention and see how we may change our plans. And then later on, once we had an idea of how we wanted the intervention to be like, we did a small test run of the intervention with a handful of patients and therapists, and we subsequently interviewed those patients and therapists as well. And throughout the Shuriken study, we have been collecting insights from our patient representatives and from members of the public. So this is our approach to developing the ACT Plus intervention. And I will now pass you over to my colleague Louise, who will tell you a little bit more about patient identification and recruitment in the Shuriken trial.
Thanks, Ellie. Okay, so hello everyone. I'm a research nurse, and I'm one of the people in the ProTech study who carries out the recruitment process, as is Ellie. So I'm just going to very briefly go through that, and starting off with the eligibility criteria. So the inclusion criteria are patients who are within 24 months of having completed their cancer treatment with curative intent or long-term remission. That also includes actually patients who are having treatment for metastasis with the curative intent as well, who are still within the 24 months of their completing their cancer treatment. They're aged 18 years or over, and they're able to participate in a talking-based therapy delivered in English. and suspected of low quality of life or some judgment that the patient would stand to benefit from the intervention. So as the research nurse, I obviously wouldn't have met that patient beforehand or know that patient. So we do a very brief quality of life assessment, which is just 3 basic questions asking about how they feel and how they rate their health and their feeling of well-being and their feeling of quality of life, to see if initially they seem to be potentially eligible for the study. So exclusion criteria will not have completed their cancer treatment before the beginning of the trial. Although, of course, ongoing medical management, androgen suppression therapy, for instance, in prostate cancer is okay and eligible. Receiving palliative or terminal care, currently receiving another psychological intervention. Medication is fine for inclusion, but as soon as they've finished their psychological intervention, whatever that might be, then they will straight away be eligible to take part in the Shuriken study if they so wish. Other serious comorbid conditions, which would make it difficult for the participant to receive a talking-based one-to-one intervention for whatever reason. And also if they required urgent psychiatric clinical psychology assessment. And of course, we would refer them to the appropriate person and place immediately. So identification of potentially eligible patients. So 2 main pathways for that. One is by staff in clinic, either face-to-face or telephone clinics. So any patient who's seen in clinic, who meets all those eligibility criteria, treatment for curative or long-term remission intent within the last 2 years, and who feel that they are experiencing quality of life reduced issues can be identified as potentially eligible for the Shuriken study. And then the study can be introduced briefly, and if the patients are interested, then their details can be passed on to the research nurse or practitioner who's working in that trust. And then that person or the clinic nurse or clinician can be in touch with the patient over the phone or in clinic to explain the study in more detail and to check their eligibility by ongoing through a screening process over the phone. And of course, patient information sheets are given out. And the patients can take their time, decide whether they're going to just study the patient information sheet first, have a little think about it, or go ahead and do the pre-screening assessment straight away. It's completely up to them. And then identification of potentially eligible patients can also be done by patient lists. And these lists can vary from surgical lists, radiotherapy, chemotherapy, lists from MDT, survivorship lists, and also end of treatment lists as well. And that's a very good comprehensive way really of actually covering or speaking to or contacting as many patients as possible who've been treated over the last 2 years. These potentially eligible patients can then be contacted by the clinical nurse or radiographer specialist or the research nurse to see if they'd be interested and eligible. And if they are interested and potentially eligible, then the patient can be screened by the research practitioner in clinic or over the phone. So the patient screening and participation. The screening tool used is the FACT-G questionnaire. I don't know if you might be familiar with that, but that's the Functional Assessment of Cancer Therapy questionnaire. It's a quick questionnaire. It takes about 10 minutes. It covers various domains such as physical, social, emotional, and functional questions. And then if the patient does score eligibly from that questionnaire, then they will be offered the paperwork to take part in the study if they would like. So there is a consent form and a baseline questionnaire that can be on paper or online, whichever they wish. And then that is actually the final eligibility step for them. Once the baseline questionnaire has been completed and been checked by one of us in the study, then they will be informed of that. And if they're happy to go ahead, then they can go through the randomization process. And that is done at the Study Main Centre, which is Queen Mary University of London. And they will then inform the patient of the outcome, and they will carry on the patient's pathway in the study after that. So the randomization process, very briefly, is 1-to-1, so 50% chance of either being in the intervention or the control group. The intervention group has been mentioned earlier, so very briefly, again, it's 8 sessions of structured therapy of ACT+. They will be sent a Macmillan Cancer Support leaflet about aftercare and usual aftercare, of course, that's currently provided by their NHS and local services. And the control group, i.e. the non-intervention group, again, receive a Macmillan Cancer Support leaflet about aftercare, and they go through that usual aftercare as currently provided by their NHS and local services. And patients in both groups, of course, are still at, free to seek any type of support that they would wish during this study as well. So study recruitment numbers to reach the target of 344 across all sites that are included at the moment. So that's at least 1 patient per cancer group per month. So that really essentially means contacting as many patients as possible and as needed to result in at least 1 patient participating per cancer group. The recruitment period is from October the 1st, 2021 to July 2023. And these are the hospital sites that are currently involved. And if you would think that your department would like to be involved as well, then we are open to recruiting new hospital sites. So please feel free to get in touch, and there's contact details on the last slide. Back over to Ellie.
Thanks, Louise. So instead of conclusions, we thought we should highlight a couple of things that we believe are important to take into account early on when planning a research project. So in our experience, we feel that it is particularly important to engage with a multidisciplinary team early on in the planning phase, as the success of a project like this relies heavily on key input from people with project-specific expertise or on the engagement of clinicians in key positions who will be able to help you recruit and identify patients as needed. And similarly, we feel that securing patient and public involvement throughout all phases of the research project is something else you need to think about early on. So in the case of the Shuriken study, we decided to devise a PPI strategy in order to consider from the very beginning of the project how to best ensure that patients' voices are heard, that we have a diverse representation of patients, and that we plan for opportunities throughout all phases of the project. So a big thank you to our funder, the NIHR, and all our collaborators. And if you'd like to hear more about our work, do connect with us online. And thank you very much for listening.
Thank you so much. What a fantastic and interesting piece of work that is. And it's great to see that you're still recruiting. We did have a question about rolling out to non-English speakers, but I can see that you've addressed that by talking about inclusivity, which is fantastic, a challenge for all of us.
Fascinating piece of work. Thank you so much. And again, we are recording this session and we will be emailing out to everybody, so you can watch it again and really take in all the rich content in there.
Yeah, fantastic.
Thank you.
Thank you very much. Do feel to get in touch with us. If you have any questions, we'll be more than happy to help outside the meeting.
What a kind offer. And don't forget, they're still looking for other centres to participate. So do step forward. Thank you. Well, it's my great honour now to announce the Gary Logue Colorectal Cancer Awards. They're now in their 8th year, and the awards were established in memory of Gary Logue to honour the contribution he made during his career. Now, Gary worked for Bowel Cancer UK as a specialist nurse advisor, and he passed away in 2014. I'm delighted to say that we've had 44 patient nominations and 16 colleague nominations this year, which is a huge amount. And we've got 2 awards to present. One to a nurse who's been nominated by her patients and their families, and the other one to a nurse nominated by colleagues. The 2 winners will each receive an engraved glass award and a £300 bursary, which can be used towards either professional development, training opportunities for their clinical team, or enhancing the patient experience. So maybe making improvements to the waiting area. It's up to you. I'm going to hand over now to the wonderful supporter of ours, Dr. Philippa Kay, who's going to tell us more.
Good evening, everybody, and welcome to the Gary Logue Colorectal Cancer Nurse Award Ceremony 2022. My name is Dr. Philippa Kay. I am a GP, and because doctors are like anybody else, I am also a bowel cancer patient. I was diagnosed with stage 2 bowel cancer in 2019, had surgery, lower anterior resection and chemotherapy, and then unfortunately further lesions were found in 2020 just before the pandemic, and I had additional multiple surgeries during the pandemic, resulting in a 2-week hospital stay right in the middle of a lockdown. So I truly understand the importance and value of the colorectal specialist nurse. Now, that role is so important and so valuable to so many people, not just patients, but also to their families and their loved ones. And actually, as somebody that can see both sides of the coin here as doctor and patient, also to the hospital staff as well. They're such an important part of that multidisciplinary team. And for me as a patient, they are somebody who I could just pick up the phone to. And in lockdown, when we were doing everything remotely, we were recovering on our own, having surgery and then recovering at home, having treatment, and essentially being on your own quite a lot. Having that voice on the end of a phone call was so important to be reassuring and to also tell you when it was that you needed to go in. To have a point of information, someone that knows the answers to your questions, and if they don't know the answer to your questions, will go and find out the answer for you and save you from going down the Warren pothole of the internet. It is such an important role, and I know that many of you do an absolutely amazing and outstanding job. These awards recognise that hard work, and it's more than hard work, right? The NHS healthcare runs on goodwill and the love of the work that the people who do it have, and without that, it couldn't exist. So I send a huge congratulations to everybody who has received a nomination, and everybody really did deserve to win, and there will be people out there who I really hope get nominated in the future to recognise the value of the work that you do. Congratulations to everybody who received a nomination, be it from your colleagues or from your patients and their family and friends. Everybody is hugely worthy of their nominations, and I hope that we all continue that good work in the future. So, the finalists for the award for a nurse nominated by their colleagues are Vanessa Sherwood from Oxford University Hospitals NHS Foundations Trust, Manju Khanna from Northwick Park Hospital, London North West University Healthcare NHS Trust, and Linda Sherwood from the Western General Hospital NHS Lothian. And I am delighted to announce that the winner is Linda Sherwood from Western General Hospital NHS Lothian. Sharon Course, who nominated her, said that throughout Linda's career, she has displayed a steady belief in the value of nursing research to address issues pertinent to patients living with colorectal cancer. She has sought to merge academic method to benefit patients through clinical practice. Linda's interest in research began early in her career when, as part of a colorectal cancer Macmillan Fellowship, she undertook and published a study evaluating the role of laser therapy in palliating the symptoms of rectal cancer. In the position as colorectal research nurse, she established a nurse-led follow-up clinic for patients following potentially curative colorectal cancer. A feasibility study was conducted from 2002 to 2004 to ensure patient safety, quality of life, and economic value could be met. It was the first study to be published and paved the way for similar follow-up practice across the UK. At this point, Linda's interest followed how service improvements can directly impact upon positively improving patient experience. Linda secured a grant for £30,000 to identify gaps within the pathway to colorectal liver resection, setting up a nurse specialist telephone support model, a patient buddy service, and developing a series of patient literature for patients being considered for colorectal liver resection. In 2020, Linda successfully completed her PhD from the University of Edinburgh in this field. She is currently working on the publications for her PhD. Linda is a well-respected and valued member of our clinical nurse specialist team. She is passionate about listening to and valuing the patient experience, knowing that if one person encountered a negative experience of care, it's very often necessary to put in place measures to ensure positive experiences for other patients. Integrating research into patient care is a way of validating and giving voice to that patient experience. And we, and that's Sharon, believe that she is a worthy and valid recipient of the Gary Logue Award. Congratulations. Good.
Just wonderful. Congratulations, Linda. Your award is here. I don't know if you can see that, everyone. And we will be sending it to you as soon as we possibly can, but congratulations. Now, I'm going to pass back to Dr. Philippa, who's going to tell us who's won the next award.
The finalists for the award for a nurse nominated by patients and their families are Maria Salter from Musgrove Park Hospital, Somerset NHS Foundation Trust, Chloe Pierce from Milton Keynes University Hospital NHS Foundation Trust, and Jackie Creedon Wilkes from Spire Bushy Hospital. And the winner is Chloe Pierce from Milton Keynes University Hospital NHS Foundation Trust. Stephanie Lawson, who nominated her for the award, said, Chloe has been with me pretty much since my bowel cancer diagnosis in 2018. She has been our support, our sounding board, and our saviour. When I had my tumour removed in 2020, I had to have a temporary stoma fitted, and it was always on the cards that I would have a reversal at some point. Unfortunately, the fallout from the COVID pandemic and other life events meant it kept getting postponed, but Chloe kept pushing and following up, and in May this year, it finally happened. This is just one of the things that Chloe has gone out of her way to do for me, my husband, and my little boy. The day before we went on our first holiday abroad since my diagnosis to France last month, she messaged to wish us a great time. These little things, they mean so much, and to know she's there for me and my family no matter what makes this whole horrific time just a little bit easier. She's not just an exceptional nurse, she's my friend. Congratulations, Chloe.
That is absolutely fantastic. Well done, Chloe. Chloe's award is here. I think Chloe isn't with us today, but I believe she sent a statement, Jen, just in case. She won the award.
Yes, Chloe says, I'm truly touched and humbled to be nominated by one of my patients for this award. Thank you for choosing me as the winner. I'm shocked and so proud. I will continue to do everything in my power to support all my patients in their cancer journey. And many thanks to all involved. Now, I'm not sure if we have also our other brilliant winner, Linda, with us today. I'm
not sure if she is still with us, but we will definitely make sure. Oh, is that Linda? That's Linda.
Oh, hello. Congratulations, Linda.
Congratulations. Really well done. That's great.
Thank you. All right. I don't know. Can you hear me okay?
We can hear you. We can hear you, but we can see you.
Goodness, honestly, this is an amazing surprise by my incredible colleagues, and it really is a privilege. I think every day, I think we can all share that to say how we try and promote that patient voice and improve services for other cancer patients in the future. But I think, as anyone knows, like, this is not a single effort, and I have to truly say that I work with an incredible group of people, and I'm going to show you who they are. I do think it's a real team effort. So thank you so much.
Oh, no, thank you, Linda. Really, really well done, and well done to Chloe as well. And I don't think I can think of a better note really for us to close on. Jen, do you?
I really can't. Thank you to everybody who nominated, wonderful colleagues for the awards. It's great to see two such worthy winners. Thank you to everyone who's presented today. We've had some incredible speakers, absolutely wonderful. A little plea for the evaluation survey. The link is in the chat and we will send it round. But if you could do it, we'd be hugely grateful, because it will really help us to make this better next year.
Yes.
And we're sorry we ran over a little bit. I think sort of inevitable given the quality of the presentations that we had.
I've loved it. It's been great.
It's been amazing. And, you know, thank you to everybody who came. I hope you found that useful. And from Claire and from me, it's good afternoon.
And thank you very much, and goodbye.
Bye.